Case Study 2 on Brenda by Sherilyn Ong, Jessica Pack, Lily Nguyen, and Sarah Strayhorn. Brenda Chen is 68 years old. She has 4 children that live close by. She likes to go out to eat. She loves cooking. She likes shopping and playing cards with friends. She used to work 30 hours a week in retail, and she was previously very independent and active. She's extremely motivated during therapy sessions, and she was transferred to an inpatient rehab center for continued medical care and rehabilitation.
Brenda was admitted to an acute care hospital with chest discomfort and jaw pain. Her EKG revealed a normal sinus rhythm with an ST segment depression, which is an indicator of oxygen starvation to the heart. She underwent a heart catheterization, which revealed blockages severe enough to indicate that heart surgery was needed. So she underwent a coronary artery bypass, grafting, and is now and then she was referred to inpatient rehabilitation for further continuation of care. So now she ambulates when tolerated, but uses her walker most of the time. She needs moderate assistance with ADLs and minimum assistance with tub and toilet transfers. Her past medical history includes coronary artery disease. She's status post left carotid endarterectomy, hypertension, hyperlipidemia, and she is a former smoker. Her allergies include iodine and latex. So Brenda's surgery was a coronary artery bypass grafting, which is due to blocking that happens in the heart because of hardened plaque that narrows the coronary arteries. A healthy vein is usually taken from the leg and connected to the blocked artery to create a new path for blood to flow to the heart. Brenda was in surgery and then admitted to the ICU for 3 days. Full recovery is about 6 to 12 weeks. Brenda's current medications include Lasix for hypertension. Aspirin is used with Plavix postoperatively to prevent clots from forming in her heart. KCL treats low blood levels of potassium. Percocet treats moderately severe pain. Lipitor treats high cholesterol. Amiodarone was used to treat her episode of atrial fibrillation. Zantac treats heartburn and acid indigestion, and metoprolol treats hypertension as well. Brenda received sternal precautions from her surgeon because she had open heart surgery, so her sternum was broken. Hers are going to last 6 to 8 weeks. They include no pushing or pulling, no lifting more than 5 pounds, no lifting one arm above your head, and no reaching behind your back. These are all just to help the sternum heal since it is a broken bone. These will affect most areas of her life, but particularly ADLs such as dressing and bathing and transfers. Some additional precautions that Brenda has because of her heart surgery is just to monitor her heart rate and blood pressure during exercises because she has such decreased endurance. An important part of Brenda's therapy is going to be educating her on energy conservation techniques. She has a lot of fatigue while she does activities, and so teaching her ways to help conserve her energy is going to be very important. So some techniques could be taking frequent breaks during an activity, planning and organizing the activities really well, and gathering everything you need for that activity so that it's all in one place. Maybe rearranging your house so that you won't have to walk as far, breaking activities into smaller steps. And also it's really important to be able to identify when your body is tired so you can act accordingly and take a break or do what you need to do for that. Educating Brenda on proper breathing techniques is also a really important part of energy conservation. So inhaling through your nose, exhaling through your mouth is a proper way to be able to get the most oxygen to your brain during activity. This can be repeated through deep breaths if she's trying to catch her breath, but these techniques should be followed while she's performing the activities.
The assessments that were done on Brenda include manual muscle testing, range of motion, functional independence measure, Borg rate of perceived exertion, and the Canadian Occupational Performance Measure. The functional independence measure measures the level of disability on a 7-point scale. This ranges from 1, which is total dependence, to 7, which is total independence without adaptive equipment. The FIM looks at 6 main areas: self-care, sphincter control, transfers, locomotion, communication, and social cognition. Under self-care, there's eating, grooming, bathing, dressing upper body, dressing lower body, toileting. Under sphincter control, there's bladder management, bowel management, and under transfers, there's bed, chair, wheelchair, toilet, tub, shower. Under locomotion, there's walk, wheelchair, and stairs. And then under communication, there's comprehension and expression. And under social cognition, there's social interaction, problem solving, and memory. Brenda's FIM scores included a 3, which is moderate assistance for bathing and dressing, and a 4, which is minimal assistance for tub and toilet transfers. Manual muscle testing is the assessment of muscle strength, and the scales from 0 to 5. 0 is 0, 1 is trace, 2 is poor, 3 is fair, 4 is good, and 5 is normal. Range of motion measures the distance and direction a joint can move. Passive range of motion is when the therapist performs the range of motion with no assistance from the patient. Active range of motion is when the patient performs range of motion with no assistance from the therapist. Active assisted range of motion is when the patient performs range of motion with some assistance from adaptive equipment such as straps or assistance from the therapist. The Canadian Occupational Performance Measure is a top-down client-centered approach. The ultimate goal of the initial interview is getting to know the clients in order to develop an occupational profile. This helps the occupational therapist identify the client's perceptions of self-care, productivity, and leisure tasks that they have difficulty performing, and the importance of the occupational task to them. The clients select 5 of the most important problems and they rate their satisfaction on the performance. There is a 10-point scale that's used for this assessment, and it measures the rate of the level of satisfaction, the quality of performance on the task, and the importance of the task to them. For the performance, 1 is not being able to do it at all, and 10 is being able to do it extremely well. For satisfaction, 1 is not satisfied at all, and 10 is extremely satisfied. For importance, 1 is not important at all, and 10 is extremely important.
Another assessment that we will also be working on is Borg rate of perceived exertion. The Borg scale measures an individual's rating of exercise intensity formed by assessing their body's physical signs such as heart rate, breathing rate, and perspiration and sweating. It's important to assess the rate of perceived exertion for Brenda during therapy sessions because we don't want her blood pressure to be too high during activities. The Borg scale will be assessed during her functional transfers, her dressing, her cooking, bathing, standing, and also ambulation. The Borg scale is from a scale from 0 to 10, 0 being rest and 1 being really easy and 10 being maximal. The first problem area that we will be addressing is activities of daily living. This includes dressing, tub transfers, and bathing.
For bathing and tub transfers, the long-term goal is Brenda will practice common functional techniques pertaining to tub bench transfer and the use of adaptive equipment for bathing. The short-term goals are: after 2 days, the patient will perform techniques to safely enter the tub using a tub bench twice a day without verbal cues and with supervision. After 4 days, the patient will practice using a long-handled brush to aid with bathing once a day without verbal cues with supervision. By the 6th day, the patient will be able to safely exit the tub using the tub bench with supervision without verbal cues. For dressing, the long-term goal is Brenda will perform upper extremity and lower extremity dressing and undressing with minimal assistance while sitting down without verbal cues about safety precautions. The short-term goals are: after 2 days, the patient will don a pullover shirt and a pair of sweatpants without verbal cues with moderate assistance. After 4 days, the patient will don a pullover shirt and a pair of sweatpants without verbal cues with minimal assistance. By the 6th day, the patient will be able to take off the pullover and the sweatpants without verbal cues with minimal assistance. There were multiple causes of problems for ADLs. The first was performance skills, and this includes motor and praxis skills. And this is because Brenda has functional limitations and her sternal precautions restrict her movement. For performance patterns, her routines have to be adapted through energy conservation and strengthening techniques. Her roles as a retail worker, a mother, and a grandmother must be adapted. For Klein factors, for her strength, she has reduced strength in both upper extremities, and when we tested her for manual muscle testing, she only got a 3 out of 5. For range of motion, this is restricted because of her sternal precautions. For endurance, due to her surgery and heart condition, she has decreased endurance, which has affected her performance in ADLs. For context and environment, her social participation with her friends is affected by her decreased endurance and fatigue. There are 3 intervention approaches for ADLs. The first approach is modify-adapt, and this is changing Brenda's environment, which is the bathroom, and purposeful activity, which is bathing, to enable her occupational participation. The second approach is maintain. This is providing support in the form of adaptive devices that will help preserve Brenda's performance abilities to avoid decrease in her function. The third approach is establish restore. This is gradually reducing the amount of assistance from the OT to increase independence of Brenda's performance in ADL, such as dressing. There were 2 frame of references being used for ADLs. The first was the biomechanical frame of reference, and the second was the rehabilitative frame of reference. For the first intervention approach, which was establish and restore, we used the biomechanical frame of reference because Brenda's limitations in strength and endurance caused us to focus on improving ADLs to improve functionality. For the other 2 intervention approaches, adaptive modify and maintain, we used the rehabilitative frame of reference because Brenda's limitations due to her sternal precautions caused us to focus on using adaptive equipment and transfer techniques. There were 2 intervention activities being used for bathing and tub transfers. The first was purposeful activity. This is providing Brenda with a long-handled sponge to access her back and lower leg and decrease the likelihood of her breaking her sternal precautions. The second was preparatory methods. This is providing techniques for Brenda entering and exiting the tub using a tub transfer bench safely. For grading the activity, we could either reduce or increase the amount of assistance by the OT or include or take away verbal cues, and this is to make it either more challenging for her or more simple for her to achieve. There were 3 intervention activities being used for dressing. The first is preparatory methods. This is educating Brenda on energy conservation techniques to decrease her fatigue and educating her on sternal precautions for safety. The second is purposeful activity. This is helping her practice the sequencing of donning a pullover and a pair of sweatpants, as well as undressing. The third is occupation-based interventions. This is having Brenda dress and undress her upper and lower extremities, which are using pullover or a pair of sweatpants, using the energy conservation techniques that she learned. For grading, we could either increase and decrease the amount of assistance from the OT and include or not give verbal cues for energy conservation techniques and external precautions. And this is to, again, challenge her or make things simpler for her to achieve.
The other problem area that we will be addressing with Brenda in therapy is under the instrumental activities of daily living with meal preparation. From the COPM interview, we noted that cooking was very important to Brenda, so that's something that we wanted to work with her on and have her be able to do. Our goals for Brenda long term will be to really increase her standing endurance to at least 5 minutes at the stove in order to prepare and heat up a can of soup with minimal assistance. The short-term goals leading up to that will be educating her on energy conservation techniques and being able to organize the meal. After 4 days, we want Brenda to increase her standing endurance to 4 minutes while performing an activity at the table while standing. And after 5 days, we want Brenda to complete the meal preparation task in the kitchen with no verbal cues for energy conservation techniques. The causes of the problems that Brenda's having with her meal preparation include the client factors of muscle functions and cardiovascular system functions. So she has decreased strength in her arms and just an overall decreased endurance because of her surgery and heart condition. So that's something to take into account. Under performance skills, most of the problems come from motor. So she's not able to endure the tasks as well. With lifting, her sternal precautions, that makes lifting certain items, or that limits that. And pacing during an activity is also hindered. So she's not able to maintain a consistent tempo during the activity. And the temporal context has been disrupted a little bit because Brenda's used to performing these activities more quickly than she's able to now. And so that is another aspect that we will be looking at. The intervention approach taken with the activity of meal preparation was establish and restore, so establishing the energy conservation and breathing techniques and really restoring her endurance. And so the frame of references that go along with this are biomechanical, which really look to enhance her occupational performance by increasing her endurance. And the rehabilitative frame of reference comes into play when we're adapting how she does a task using these energy conservation techniques so that she can maximize her performance. The first intervention activity for meal preparation is going to include educating Brenda on the energy and breathing techniques stated earlier. So, gathering all the materials beforehand, everything she needs to cook, being able to take rest breaks when she gets tired. This intervention activity falls under the type of education. The rationale for this is it fits with a rehabilitative frame of reference because we're helping her to adapt the task so that she will be able to better engage in this occupation. For grading, making it harder, less verbal or visual cues, and grading it down, cueing her more if she's having trouble with that. The second activity we'll do with Brenda for meal preparation is an activity-based intervention type. So to help increase her standing endurance to 4 minutes for this session, we'll have Brenda engage in a card game at a table while standing. So the OT will be looking at whether Brenda is utilizing the energy conservation and breathing techniques that we taught her in the previous session, or if she needs further cues while performing the activity. So the rationale for this is it does fit under the biomechanical frame of reference because we're trying to increase her standing endurance. But while the biomechanical frame of reference is a more bottom-up approach, this also incorporates a more client-centered approach because Brenda does enjoy playing cards with her friends, so this activity attempts to merge both of those. For grading, to make it harder, you could increase the time needed to complete the game, a more complex game where she would need to be standing longer. To make it easier, increasing the rest breaks or having a simpler card game that doesn't require as much time.
Therapy will be delivered by an occupational therapist and an occupational therapy assistant. Therapy will occur in the rehab gym, the kitchen, the restroom, and also the hospital room. ADL training will occur in the morning and IADL training will occur in the afternoon. And the frequency of therapy sessions will be 60 to 90 minutes a day and 6 days a week. An important part of discharge is assessing Brenda's functional independence at home. It's very important to assess how much assistance Brenda will be requiring at home and also who she will be living with during the time. Some parts that we can look at is identifying routine roles and habits that will affect daily occupations at home negatively and positively. Before Brenda is discharged, we recommend a home assessment to evaluate the barriers that she will be having at home and the community. The Home and Community Environment Instrument will be used to assess this area. It addresses home mobility, community mobility, basic mobility devices, communication devices, and transportation factors. Occupational therapists routinely use occupational therapy home programs as a therapeutic strategy. At the time of discharge, Brenda will be recommended a home program. A home program will consist of giving information on stretches and mild exercise, and also being mindful of her sternal precautions. One of her sternal precautions is that she needs to avoid lifting, pushing, or pulling anything greater than 10 pounds for 6 to 12 weeks. We also need to address her limited endurance. She needs to focus on pacing herself during activities and also work on simplification techniques. Training with family members is also very important because Brenda will be needing some assistance when she's being discharged. Brenda will be discharged to her home and will receive home care services for nursing care, physical therapy, and occupational therapy.